Welcome. I'm Joel Moskowitz, the Executive Director of the America-Israel Cannabis Association, known as AICA. AICA was formed to unite top-tier research and technological achievements of the Israel cannabis industry with the burgeoning American market. This is our inaugural event, and I am so proud and grateful that Dr. David Casarett has agreed to speak with us today. Dr. Casarett is Professor of Medicine at the University of Pennsylvania's Perelman School of Medicine. He is the Director of Hospice and Palliative Care at the University of Pennsylvania Healthcare Systems. He is also an accomplished author. Most recently, Dr. Casarett has published Stoned, A Doctor's Case for Medical Marijuana, and it is the publication of that book that brings Dr. Casarett here today. Dr. Casarett, thank you so much for coming.
Oh, thanks. It's great to be with you.
Okay. Why don't you please start by telling us how you came about discovering medical marijuana?
Sure. It's a weird story. It was actually a patient of mine. So a patient came to me. I'm a palliative care physician. I take care of patients who are near the end of life, often with difficult to manage symptoms. And she came to me with pancreatic cancer, pain, and nausea. And she asked me in that initial consultation whether I thought that medical marijuana might be helpful to her. And I told her what I learned in medical school, which was that marijuana is an illegal drug. There are no medical uses for it. It's addictive and it's something to avoid. And then she reached into her handbag and pulled out a couple of research articles, randomized controlled trials of the use of medical cannabis for symptoms like the symptoms that she had. Studies by people many in the audience will recognize. Barth Willsey was one, Donald Abrams was another. And she pulled out these articles. And I realized at that moment that this patient of mine actually knew more about medical cannabis than I did. So I promised her I would look at the studies. And those studies led me to talk to patients, researchers, find other studies that had been published. I really began to change my mind about the potential benefits of medical cannabis. Initially, I thought it was just a joke, but it turns out I was surprised to learn there's some real science there.
Well, I want to go back to the joke comment because it's not the first time I've heard you use that, and it's not a secret that when you speak to just the average person on the street and you talk about cannabis or as it's better known, marijuana, the first thing that comes to mind is Cheech and Chong and Jeff Spicoli from Fast Times at Ridgemont High. But you're saying that you found some research, or she gave you some research. So and you've discovered that it's not really a joke, but the problem is that we don't have, or there is limited research here in the U.S. For medical cannabis. And again, one of the reasons we formulated the America-Israel Cannabis Association is because Israel has been doing exhaustive research on cannabis for over 40 years. So tell us how you discovered it's not a joke and what you've learned about it as a useful drug or medication.
Sure. So in researching and writing Stoned, A Doctor's Case for Medical Marijuana, I had a chance to talk with a lot of researchers. And, it was really those researchers, those serious scientists who got me thinking about medical cannabis in a new way. And I think chief among them is Israel's own Raphael Mechoulam, who took part of the day out of a very busy schedule to sit down with me and walk me through the science of cannabis, but also, more importantly, the science of the endocannabinoid system. And I think of everything that I learned, that recognition that there is in all of us an endocannabinoid system, and that the cannabinoids in marijuana, THC and CBD for the most part, but certainly others as well, do what they do by hacking into that system. That for me was really eye-opening. It wasn't just a matter, once I learned that, it wasn't just a matter of the Cheech and Chong that you mentioned of getting high, but there really are molecules that bind with receptors, not just in our brains, but in our immune system, elsewhere in our bodies, that begin to have the effects that they do. So that for me was really a turning point.
And did it only lead you to pain management, or did you discover other medical uses? I know that it's very, very popularly known that some form of medical marijuana is good for seizures. Did it lead you to any of the other research in that area?
Yeah, certainly. was led, hopefully, to most of the research that's out there. This wasn't an exhaustive review, but I really tried to take a look in all the corners of research that have been done. Certainly, the most research that's been done, as far as I can tell, is on pain, particularly neuropathic pain, so pain due to nerve damage, at least in part because I can tell you as a palliative care physician, that kind of pain can be really difficult to treat. People with neuropathic pain often don't respond well to opioids. Opioids make them feel sick or sleepy or nauseated, and they don't provide much relief.
Could you tell us the difference between neuropathic pain
Mhm.
and what other pain is?
Sure. So neuropathic pain, the fundamental element of neuropathic pain is that it comes from an injury to the nerve itself. It comes from some form of nerve damage, some reason why the nerve itself is misfiring, is creating static that our brains interpret as pain. Neuropathic pain happens sometimes after trauma, sometimes after chemotherapy with conditions like diabetes. There are also elements of neuropathic pain that are present in conditions like multiple sclerosis. But the problem there is fundamentally with the nerve itself. And that's different than the normal so-called nociceptive pain or run-of-the-mill pain. If you sprain an ankle or break a leg, that's a perfectly normal nerve that's responding to a painful stimulus. And that kind of pain, a broken leg kind of pain, that responds really, really well to a lot of other treatments, even Tylenol, but certainly opioids, and is usually pretty easy to treat.
So you, in your role as the director of hospice, and being in Pennsylvania, which does not have any legalized cannabis there, you have to prescribe opiates for your patients when they're in pain. Would you like to be able to prescribe them something other than opiates? And obviously, I'm getting towards the cannabis thing. Is that something that doctors like yourself are eager to pursue at this point?
Well, you had me until you asked me about doctors like myself. I think I certainly would strongly consider recommending medical marijuana for some of my patients, particularly those with neuropathic pain. You mentioned other symptoms like nausea, particularly nausea related to chemotherapy. I think there are several indications where I think the data for medical marijuana are fairly good, and I would certainly strongly consider it. The other doctors like me, I'm not sure. I think there are certainly some physicians like me who work in palliative care who see patients with really difficult to manage symptoms and who have a pretty realistic understanding, I think, of what our current drugs can achieve and where they fall short. But the general population of physicians out there, in the United States at least, I think is still fairly skeptical. So palliative care physicians may be fairly enthusiastic, but others, internists, oncologists, cardiologists, I think we're going to have some work to do to begin to get them to be open-minded. Maybe I'm wrong. I hope I am.
Well, I'm going to get back to that. We are speaking to a crowd of, it's like preaching to the converted or the choir. So this is not the general public. So I want to just veer away from the line of questioning for a second and play a quick game. I'm going to give you a list of some things that are legal, and then at the end I'm going to put in cannabis and tell me which is the worst one from a medical point of view, in your opinion. Alcohol, tobacco, saturated fats, sugar, cannabis.
I'd have to say probably tobacco because there's no therapeutic benefit, and the risks of tobacco really are pretty significant.
All right, but again, if you were making your list, you had alcohol, tobacco, saturated fat, sugar, cannabis. Would cannabis be on the bottom of the list?
If you ask me what order they're in, yeah, honestly, I would put it pretty close to the bottom. Keep in mind, though, I mean, if marijuana were used as commonly as tobacco or alcohol or saturated fats, the risks of marijuana might be higher. I don't mean to escape a legalistic answer, but I mean, imagine if everybody in the country smoked marijuana recreationally or medically, you could begin to see more health problems potentially, or more problems with addiction.
Well, some people
but
would
just
argue
based on
that.
that list and the way that people use it, I'd have to say that I'm less worried about marijuana than I am about anything else on that list.
Right. I'm not trying to be overly humorous here, but most people would tell you that if everyone was smoking marijuana, there'd probably be no shootings and less street fighting. But along those lines of questioning, does it bother you in any sense that since you've approached cannabis from a medical point of view, does it bother you in any sense that, in essence, the movement to legalize cannabis in the country is really using the medical marijuana direction as a gateway to really open up marijuana exactly the way you described it, like alcohol, like tobacco, as a product that can be consumed. I mean, this is, the medical benefits are there. It's being proven scientifically. There's arguments for or against it, but it's being utilized by a great many people to open it up. Is that a dangerous avenue that we're pursuing?
I don't know. I don't mean to dodge the question, but I feel like I'm not really qualified to comment on it. Mostly because I'm a physician. I treat patients with serious illness who have difficult to manage symptoms. And so when I thought about the possibility of writing a book about medical marijuana, I thought, yeah, I've got the moral authority to weigh in on this. Because if anybody knows what symptoms cause in terms of suffering, and what people feel like, and what our drugs can and can't do, and whether there's a role for medical marijuana, it would be somebody like me, because I see the hardest to manage symptoms. The whole recreational use issue, that's not so much a medical question. As a doctor, I'm not any better qualified to comment on that than I am to weigh in on immigration reform or same-sex marriage. I'd be happy to give you my opinions on those, but
well, no, but
it wouldn't necessarily be intelligent ones.
You might be able to tell us what long-term effects use
Sure.
of marijuana can have, or even the cognitive side effects that you have using it on a medical basis, and based on that, project that perhaps overuse could be dangerous in certain ways. And as a follow-up to that, the technology has changed. The way it's ingested, the way marijuana is ingested today, is completely different. It's actually going back to the old way, which is either to eat it or oils, or to vaporize it, as opposed to smoking, which takes away some of the inherent danger. Any opinion on that?
Sure. And I guess I would add to that list tinctures. John Clendenning and William O'Shaughnessy were famous for pioneering the use of tinctures more than 100 years ago. And now you have pharmaceutical companies like GW Pharmaceutical manufacturing and selling THC and CBD in the form of tinctures once again. So there are a lot of other forms. You asked about risks, and I guess my quick summary is there are a lot of surprises there for me. I thought that if you smoked marijuana, you would almost automatically get lung disease, because the same smoke and particulates that cause lung disease and lung cancer in the setting of tobacco, you'd think would also cause it in the setting of smoked marijuana. I was really surprised to learn that, based on the research of Donald Tashkin and others, that actually doesn't seem to be the case. I've looked at a lot of those studies, and I've been pretty convinced that smoking seems to be pretty safe in terms of lung damage and lung and throat cancer. And then, obviously, edibles or vaporized cannabis would be completely safe. You also asked about the risks of long-term cognitive impairment in medical use. And I'd say we really don't know. All of the studies that I was able to find on long-term effects on brain structure or function were in recreational users, and often in recreational users who used, frankly, a lot of other drugs. So you've got some kid who's using recreational marijuana 7 times a week, is also using alcohol, tobacco, crystal meth, heroin. He may wind up with some brain damage or at least measurable impact 20 years later, but that doesn't necessarily mean that as secretary from Dubuque, Iowa, who uses an edible once a week to get to sleep, that doesn't necessarily mean she's going to have cognitive problems in 20 years. So I really don't think we know, and I think my guess is that a lot of the reports of long-term cognitive effects of marijuana use in recreational users may not pan out and may not be significant at all in people who are using differently. And that's probably true of addiction too. My guess is that the risk of addiction is probably much, much lower among medical marijuana users than it is in recreational users who may use in a different setting, may use socially with a lot of other drugs. That's just a suspicion, but I'm much less worried, I think, about medical uses than some of the literature from recreational uses would suggest.
So in your book, you had some humorous anecdotes about self-testing, and based on what I've read, so you weren't necessarily one of those college kids that was spending his college years partying up a storm, I guess. So you tried this stuff, and you had some interesting experiences. Can you tell us a little bit about that? And do you think that those are common, or that yours were, for some reason, maybe you took too much, took too little, took the wrong strain? What can you tell us
before
about
I answer that question, a little bit of background is useful. So you're right. In Stoned, I did try to come up with a lot of sometimes humorous or at least interesting anecdotes. And I did that really, really strategically because I wanted to make this a fun, easy, interesting read. I didn't want to make this all about the science, but I did want the science. I really wanted people to read my interview with Raphael Mechoulam so they could begin to understand the endocannabinoid system, but nobody wants to read about molecules and receptors. So I tried to add in my own anecdotes to try to keep people engaged and keep people reading. Regarding my experience, this was for an episode of low back pain. Anybody who's watching this who have ever had one of these episodes knows that's one of the not so pleasurable aspects of middle age. You're minding your own business, you lean over to tie your shoes, and all of a sudden you get this horrendous back pain, so bad you could barely move. And it was at that point, as I was researching Stoned, that I had begun to see, I thought, some of the real benefits, and I began to understand some of the science, and I thought that would be a great time for a little self-experimentation. You asked about some of the experiences that I had. Yeah, I think the technical term for what I did, my friend and colleague Clint Werner tells me, is called overtoking. So was a pretty naive user, was having a lot of pain, thought that if 1 or 2 puffs could be helpful, then 10 or 12 puffs would be even more helpful. Probably overtoked by a factor of about 10. Had some really interesting visual hallucinations, auditory hallucinations, was convinced there were these air traffic controllers camped out in my living room. I will say my pain got better. That's the good news. But those sorts of symptoms, those side effects, particularly hallucinations, are really, really uncommon. I think the lesson there for me was not that marijuana is dangerous, or certainly that those sorts of side effects are common, but to the degree that those sorts of side effects at least happen sometimes, they're pretty much entirely avoidable if you get your medical marijuana from a dispensary that tests and lets you know what's in them. And that's been a big battle cry for me in thinking about the benefits of medical marijuana, letting patients get access to safe, reliable medical marijuana and other products that whose contents you know. So you know what the THC concentration is, you know the CBD concentration is, among other cannabinoids, and you know what a dose was. So that was interesting to me, but it wasn't interesting as a scary side effect of marijuana. It was just a call for testing marijuana in the same way that we put packaged spinach you buy in the grocery store through testing. It's the same argument for me.
So there was an interesting development in the state of Israel in the last couple of weeks. That the health ministry has now given permission to regular pharmacies to dispense medical marijuana, and that leads me into to the second part of what I'm trying to say and get to the question. Here in the United States, we've now legalized marijuana in 23 states, in the District of Columbia, and but we seem to have very little protocol. And we're learning as we go. In fact, one of our other speakers is Andrew Friedman, who's the first ever marijuana czar for the state of Colorado. In a 60 Minutes profile on the industry, he talked about how they're really trying to create a protocol, because you mentioned dosages and things like that, and the strains. So in your research, What did you find out about that? Are we going to change how we purchase this on a medical basis instead of going in and saying, I'll have some of the chocolate whatever purple this or I'm not very good with the strains. I'll need a few cc's of pain relief or is that how the direction we're going in?
I'd love to see us go in that direction, honestly. The challenge right now is that I just don't think we nearly have enough data and evidence to be able to guide those decisions. So yeah, you would be great to be able to go into a dispensary and say, look, I've got pain due to a condition called lupus. It's mostly neuropathic pain. Right now my pain is an 8 out of 10. I'm on these other drugs. And that would be enough information for somebody to look through published studies and say, yeah, for you, the optimum in terms of benefits, side effects, the optimum would be maybe a THC concentration of 4% and a CBD concentration of 12%, and it'd be most effective in an edible. Like that would be an ideal world if we had enough randomized controlled trial data on enough people to be able to say, this is what works for you. In the same way that if you go to an oncologist with breast cancer, they can look at your cell types, they can look at estrogen receptor profiles, they can look at the degree of spread and the pathology and say, this is the chemotherapy regimen that's right for you. But that's the product of 40 or 50 years of clinical trials. And right now in the United States, we've just got a handful of really good clinical trials. So that's exactly where I think we need to go. But to get there, we need a whole lot more research than what we've got
and
now.
are they allowed to use the research that's been done, say, in Israel, exhaustive research that's been done in Israel? Is there something blocking the research that has been done there legally for the last 40 years, like by Professor Mashroom and others? Is there anything preventing doctors like yourselves from using that research to pursue an avenue to make it a little more widespread?
No, I don't think so. I mean, in terms of changing legality and schedules, there may be limitations on where that research needs to come from. I don't know those laws at all, but I know enough to know that sometimes laws cannot make a whole lot of sense. No, but I think certainly when I reviewed the literature and came up with my assessments of what seems to work, particularly for nausea. So my sense was a lot of the best research on cannabinoids for nausea came from outside the United States. That didn't stop me from saying, yeah, that seems like a pretty good use for cannabinoids. And hopefully other physicians would be open-minded, especially in today's global community and global economy. We take good quality evidence wherever we can get it if it'll help our patients, whether that's medical marijuana or chemotherapy or anything else.
Okay, many of us in the industry believe that legalization is actually becoming a human rights issue on various levels. There's the racial component of incarceration of men of color for the same amounts of carrying the same amounts of marijuana that proportionally are held by white people, but that's not your area of expertise. Your area of expertise is in medical care. And the question is it becoming a human rights issue, sort of the way right to assisted suicide or someone ending their own life? People are framing that in terms of it being a human rights issue. Is access to medical marijuana or access to marijuana in general, is that a human rights issue in your mind?
It's a really interesting way to frame it. I would actually give you a different analogy, which I think gets you to the same point, but in a different way. Think back to the 80s when AZT, the first really promising AIDS drug, came out. And back then there were some really interesting divisions and discussion. There was, on the one hand, researchers, scientists, and regulators at the Food and Drug Administration in the United States in particular, who said, well, we can't make this available to the general public. We only have some animal studies and some preliminary human studies. On the other hand, you had AIDS activists who themselves were at risk of dying. They were seeing friends and lovers dying all around them, who were saying, they were looking at exactly the same data, but they were saying, hey, you have animal studies, you have preliminary human studies, that's enough for us. And I think we're arriving at much the same place with medical marijuana. You have some researchers, some very conservative physicians, policymakers saying we need much more data. And you have other people, like many of the patients I talked to, who said, look, I've had this awful neuropathic pain. morphine doesn't help me, actually makes me feel miserable. I've tried 7 other drugs, none of them help. I know there aren't good randomized controlled trials necessarily for this particular kind of pain for me, but don't I have a right to give this a try, particularly when nothing else has helped? So the right is not so much access, but it's a rights question of how much evidence you need, how much evidence we need to demand, I guess, to give patients access to something that could help them. So I definitely see it as a human rights issue on the medical side, albeit in a slightly different light than what you described.
Well, I want to thank you. We're running out of time. I want to thank you, and I want to say to our followers and listeners that it's advocates like you that are going to help us get where we need to go. The book is called Stoned, a doctor's...
A doctor's case for
medical marijuana, and I'm sorry I didn't get it off the top of my head. It's available at davidcasarett.com. Casarett is David Casarett. Casarett is spelled C-A-S-E-R-A-T-T? No.
C-A-S-A-R-E-T-T, but you can also get it on Amazon or Barnes & Noble. It's available as a print book or as an e-reader copy.
Yeah. So I suggest everybody get it. And I thank you, Dr. Casarett, for being with us today, and look forward to seeing you at our next conference.
Thanks. This has really been a lot of fun. Your questions were really great, thought-provoking, enjoyed it a lot. Thank you.
Thank you.